Good morning, everyone. My name is Stacie Miller. I'm the Oncology Clinic Manager at UT Southwestern here in Fort Worth, Texas at Moncrief Cancer Institute. And I have the pleasure of being your moderator for this morning's session. We have a great treat in store for you guys, so we hope you are engaged and ready to talk with our panelists for this morning. This morning's topic is Advances in Colorectal Cancer Diagnostic and Testing and Treatment. This session will provide participants with a look at the role that genetic and molecular diagnostic tests play in bridging the transition from colorectal cancer screening to treatment, and an overview of current treatment options and recent advances, all set into context by the lived experience from our colorectal cancer survivor. So with that said, we will start first with our colorectal cancer survivor, who unfortunately is not able to be here with us today. Not health-related reasons, which is great. She's doing well in her health, but she recently got a new job, and so she wasn't able to travel for today's meeting. So we'll talk a little bit more about her story here in a second, but also after we show the video, we will have Dr. Swati Patel, who is coming to us from Coach Prime State University of Colorado, right? Tell Coach Prime we said hello. The Anschutz Medical Center. And then our third presenter will be Dr. Andrea Cercek from Memorial Sloan Kettering Cancer Center. Okay, a little bit about our cancer survivor. Her name is Flores, and I'm going to read a little about her story. In January 2020, at the age of 54, Flores was told by her doctor that she was overdue for colorectal cancer screening. When she was sent her Cologuard at-home testing kit in the mail, she didn't think much of it. A real estate agent from the Port Luisa, Florida, Isla promptly mailed back her test kit to the lab and checked it off her to-do list. 4 days later, her doctor called her to tell her results were positive. She was floored. She says, "I was convinced that the test was going to be negative. I had no symptoms. Nothing was wrong. So when I got the positive test, I was completely blindsided." Ela was told that she would need more testing to find out the significance of her test results. So she called a clinic to schedule the colonoscopy, still naive to exactly how or what the next steps would bring. It's a whole process, she says. You call, you tell them that you got a positive result on an at-home test kit and that your doctor has referred you to get a colonoscopy, she said. So her colonoscopy was scheduled on March 19, 2020, in the height of COVID-19 pandemic. You can only imagine, right? It was just shortly after the world shut down, right? And the only thing was happening was medical emergencies at that time. We had delayed care for non-essential medical needs, such as cancer screenings. But Ela was very fortunate that her screening center stayed open long enough for her to get her colonoscopy scheduled. And here is her story.
Hello, everyone. I am so sorry that I cannot be there with you this year at the NCCRT, but I want to say hello to everybody, and I want to thank you for everything that you're doing. And I want to tell a little bit of my story. So here we go. My story starts in 2020, March actually of 2020, March 19th. And if anybody recalls what was happening around that time, the world was shutting down for COVID. And March 19th, I go in for my first colonoscopy ever, and I am told by the doctor that did my colonoscopy, "I think you have cancer." I'm hearing these words like advanced, aggressive, and my whole world just started to spin around. She immediately did a biopsy, sent me to a surgeon who, by the way, was already shut down for COVID. So I'm running up against these walls where these appointments that I need to go on are kind of not happening. So there was basically slim pickings. So I ended up actually finding a surgeon through a friend. And actually I was terrified to go to the surgeon because I didn't have anything because everything was shut down. So I had to go for blood work. The blood work wasn't back because of COVID. I had to go for a scan to determine, they called it staging. I didn't really at the time understand what that was. So I went for a scan, and as I was leaving, I was able to get an appointment. But when I was leaving, they were turning the sign saying that they were shutting down for COVID. So I didn't have anything. I remember I asked them for a CD. They did not have the reading, the radiology read or anything like that. So a few days later, I was able to get into the surgeon, and I was terrified because I thought he was going to say to me, hey, go home. When you have everything, come back. But, he was a very kind doctor, and he looked at the only thing that I had, which was the CD. He put it up on the screen and said, you know what? He goes, that needs to come out. When would you like to have surgery? And I was like, what? And he scheduled it for the next day, but unfortunately we had to wait a little bit of time, 24 hours, for insurance to approve it. And they did approve it. So a week later, I was in surgery having a foot of my colon removed. And it all just happened so fast. I did not have time to really think, to comprehend. Looking back now, I think, I would have maybe taken just a little time to do a little bit of homework and look at different types of options for my situation. But I really felt pressured at the time, and not having dealt with anything of this sort. I don't have any type of family history. I did not have any symptoms at all that I still look back, to this day, and I say to myself, how? I don't know. There was no family history and no symptoms. I don't know how this happened. So with all that being said, it was such a shock to me that I didn't realize, or even think of other options. Nothing else was offered. It was like, okay, I went for this colonoscopy. You have cancer. You have to do this. You have to do these steps to go see the surgeon. It has to come out because eventually it's going to obstruct. And then you need to you're being staged, and you need to go to an oncologist who will do all the work and stage you and consider what type of treatment. But it was basically like one treatment. It wasn't anything else. Nothing else was actually offered. So subsequently, I went through 6 months of chemo, and that was rough. But here I am today, and I'm okay. I just think to myself, perhaps I would have done things a little bit differently. The setting of care and support services, I would honestly say are pretty much non-existent from my personal experience. There's so many things they don't tell you. I feel like there's a missing piece when it comes to the patient, the doctor, and then what actually happens in between of having treatment. I would have liked, or it would have been nice to have, somebody sit with me and say, okay, this is what you are to expect. This is how you can prepare for it. But really, it was more like a trial and error. I went in for my first chemo treatment and then kind of figured out, okay, listen, you need to hydrate, you need to eat a certain way, to be able to fight, because it literally is a fight, and you have to fight and you have to prepare yourself for the battle. But I didn't really understand that. And I didn't really understand the symptoms of chemo and the thing, how your body responds to it, and even some of the lasting things that you have to deal with as a result of having that type of heavy treatment. So I really feel like there is an opportunity there for that in the future, for somebody to take on that position. But that wasn't the case in my situation. Maybe for others that has been, there has been a very good support system. That's pretty much it for me. I really feel that I did get good care through my hospital, and my oncologist was wonderful. So from that perspective, like I felt trusted. I felt like she cared. So that was really wonderful. Anyways, guys, thank you so much for taking the time to listen to me. And like I said, I really wish I could be there with you guys, but I'm there in my heart. And I hope you guys have a great meeting. Take care. Bye.
Hey. We would like to thank Miss Ela for being so brave and sharing with us her story, even, just through streaming video here. But a couple of other things that she wanted us to point out in the email that she sent as to why she couldn't be here today. As I mentioned, she recently started a new job, right? She is an independent real estate agent in the state of Florida. And being self-employed, as we all know, has its challenges as far as the healthcare system, right? So I see a lot of head nods in the room, like it does. And we see this story happening all the time, right? So she recently started a job, a day-to-day desk job, as she says, so she can have affordable, reliable healthcare coverage now that she's going through this cancer journey. She states she literally could not sustain the high cost of insurance that she was paying before. As she was mentioning, she took months for the insurance to approve when she started her treatment. So as a full-time realtor, she was basically self-employed, plus she was single, so she was spending lots of money on healthcare coverage. So she had to make the important decision to get a job so she can have reliable healthcare coverage. She had been paying somewhere between $600 to $1,000 a month in insurance for the past 3 years. She chose a PPO plan that she felt gave her the best care as a survivor and the ability to choose a specialist rather than having to go to a HMO where she would need a referral first. And so that was part of her choice when she was picking her healthcare plan. But she wanted us to know that insurance is so important also in this process as we talk about treatment, and honestly can dictate the level of care that patients receive. If we think about our uninsured population, our undocumented population, the same is also true. It plays a huge role in the choices we get for treatment and care. So with that said, I will now bring up our first panelist in the room, Dr. Swati Patel.
Thank you very much. Good morning, everyone. It's really wonderful to be here. I think the story that Ms. Flores shared centers us and, really highlights the critical importance of why we do what we do. And so I'd like to thank the NCCRT for this invitation, and in particular, the leadership of Dr. Steve Itzkowitz, who has ushered this kind of transition for the NCCRT to improve cancer care through the continuum, because we see these disparities all the way through mortality, and the focus thus far for a long time has been on improving screening and prevention, and I think kind of expanding this approach and the reach of NCCRT can really impact our patients. So I'll be spending the first part of this session talking about the evolving approach of molecular and genetic testing in colorectal cancer, with a focus on screening, and then Dr. Cercek will carry that topic into how it really will help us personalize treatment for our patients. These are my disclosures. The only ones that have maybe some impact on some of the discussion is my role on the NCCN colon cancer screening panel, as well as the U.S. Multi-Society Task Force. So this term, cancer genetics, gets thrown around a lot. We'll start the talk by just kind of briefly reviewing what we actually mean by cancer genetics. We'll talk about the kind of emerging role of molecular and genetic testing in the screening process, and then, of course, our evolving approach to germline genetics. So fundamentally, cancer is in fact a genetic disease. We know that there are multiple factors that interact to influence cancer risk, but on the very basic level, we think of cancer as a genetic problem. Whether that be in colon tissue or whatever other end organ you're thinking about, there's genetic changes that happen within that cell, whether it be in how cells move, how they divide, how they grow, how they migrate, what we call kind of tumor suppressor genes or oncogenes. Mistakes in those fundamental genetic code of these cells leads to abnormal growth of those cells and eventually precancer and cancer. So when we think about the role of genetics, molecular genetics in screening, this has been an area that has really been rapidly evolving over the last few years. This was really kind of a different way to present what Dr. Itzkowitz showed us this morning. When we generally think about cancer, theoretically, all of us are born with cells that are functioning normally, normal DNA, but changes over time can potentially accumulate. And if they accumulate in kind of an unfortunate combination that causes a cell to not function normally, then unfortunately those mistakes can get propagated and then essentially lead to abnormal growth of that tissue, which can then progress to a cancer. And when we think about the colon, this is really the progression of normal colonic mucosa to precancerous polyps to cancer that we think about, these accumulated combinations of genetic changes that unfortunately lead to cancer. For colon cancer in particular, what we thankfully understand is that that process can take a long time, up to 8 to 15 years for normal colon mucosa to progress to cancer. And so another way that us as GI endoscopists think about this is sort of the progression from precancerous polyps to colon cancer. And we saw a depiction of this morning. And we have the opportunity to really do screening and intervene upon things before they turn into cancer in the form of cancer prevention tests, but then also in early detection where we can find cancers at curable stages. And so typically we think of our structural tests, such as colonoscopy or CT colonography, as being able to detect precancer and cancer along the continuum. And historically, we've really thought of our stool-based tests, the FIT test, the Cologuard test, as tests that are quite good at picking up early stage cancer before it causes symptoms, as it did in Ms. Flores. And then up until recently, there's been disappointment around the role of blood-based tests because they really weren't that good at detecting cancers at earlier stages. But that, of course, is an evolving story, is a hot topic recently and certainly as during this meeting. But just as a review, when we look and compare how good these tests are at detecting colon cancer, you can see that the structural tests, of course, are very good at detecting colon cancer with sensitivities above 90%. And they're actually very good at detecting the precursors to colon cancer, advanced adenomas. The stool-based tests historically have been quite good at detecting early stage cancer with sensitivity of 80 to 90%, but as you can see, not as good at detecting precancerous polyps. Of course, there's been a lot of attention and really important publications over the last year that have been pushing the boundary to what tests we can offer our patients in the screening realm in the form of both stool-based tests, so a new generation of the multi-targeted stool test, as well as a new stool RNA test to detect kind of cancer in the screening phase, and then, of course, emerging blood-based tests. These are publications that have come out over the last year about all these tests, and we'll hear a lot about them. We heard about some of them yesterday throughout this meeting, but it really does expand the types of screening tests that we can offer our patients, such that now we have a blood-based test that has an 83% sensitivity for detection of colon cancer, stool-based tests that push almost 95% sensitivity for detecting colon cancer. And then, of course, in terms of the precancerous polyps, we can see that the stool-based RNA test actually performs much better historically than the previous stool-based test for detection of precancerous polyps. So in fact, the emergence of these molecular tests in the screening phase are actually improving our options for our patients. And these stool-based tests that historically we thought really were in the realm of just early stage cancer detection are improving in their ability to detect precancerous polyps. And the blood-based tests, which we previously really did not rely upon for cancer screening, are showing improved sensitivity for detection of early stage cancer. So in general, we know that all cancers, solid organ cancers, about 60 to 70% occur in the absence of any family history or genetic or hereditary predisposition. Maybe about 25% or so have some familial component, and up to 10% have a true hereditary predisposition. And for a long time, all of these screening tests that we've been talking about are really focused on those that have no family history or no hereditary predisposition. And this is an important piece of the pie to focus our efforts on. And so it's a piece of the pie that the NCCRT has been committed to for a long time. But I'd like to now just shift gears and spend some time talking about that 5 to 10%. It's a small piece of the pie. Why should we focus on this? Well, I'll try to make the case that it's really a critical area for the NCCRT to continue its work in. So we talked about how cancer develops in most individuals. Theoretically, born with normal genetic code in these tumor suppressor genes, oncogenes, mismatch repair genes, and it's just a matter of successive random mistakes that happen that lead to cancer. Well, in our patients with hereditary predisposition, they're unfortunately born with an inherited mistake, and it really is an accelerated pathway to development of colon cancer. And so why should we focus on these individuals, albeit at high risk, some at up to 50-60% lifetime risk of getting colon cancer, such as in Lynch syndrome, if they're such a small piece of the pie? Well, we all know it's a really big pie, second leading cause of cancer-related death in the United States. Not only is it a big piece of the pie, but we can make a huge impact. We have the opportunity to intervene across the spectrum, all the way from prevention, early detection, out through treatment. I won't go through all of this in detail, but for example, in our most common hereditary GI cancer syndrome, Lynch syndrome, which can carry up to a 60% lifetime risk of colorectal cancer, we can eliminate cancer risk altogether with risk reduction surgery. These patients are at risk of other cancers, such as gynecologic cancer. We know that medicines can significantly reduce the risk of colon cancer in Lynch syndrome, with aspirin showing a 50% long-term risk reduction in patients with Lynch, such that we only have to treat 24 Lynch syndrome patients with aspirin to prevent one colon cancer. Emerging dietary interventions that have been shown to decrease risk of cancers outside of the colon. Emerging data on the importance of exercise to potentially be protective of cancer in Lynch syndrome. And then, of course, really pushing the boundaries is the research that's currently being done in vaccines that have the potential to prevent cancer in Lynch syndrome. So yes, Lynch syndrome patients, the most common hereditary syndrome, are at significantly increased risk of cancer, but we are increasingly finding ways to decrease that risk for these individuals. And then, of course, what we do in the GI lab, and that is finding these advanced polyps, removing them, and preventing the natural progression to cancer. For those diagnosed with cancer, we have incredible opportunity to prevent a second cancer by customizing their surgical treatment. We recommend more extended colectomy in patients who have a high risk of getting a second cancer because of their genetic predisposition. And then, of course, as Dr. Cercek will review with us, depending on the molecular characteristics of a tumor, Lynch syndrome patients can significantly benefit from customized approach to chemotherapy in the form of immunotherapy. Genetic conditions are, in fact, genetic. So not only can we implement all of these risk reduction interventions in our patients, but we have this awesome opportunity to cascade this prevention benefit through their family members. So many of these genetic conditions are what we call autosomal dominant. So first-degree family members are at a 50% chance of having the same risk. And we can systematically make our way through the family, identify individuals who may be at risk, understand whether they have that genetic risk, and essentially have the opportunity to offer all of these individuals, whether they've been diagnosed with a cancer before or not, these prevention opportunities. So to me, even though 10% of the overall pie is a small proportion on its face value, we actually have a significant opportunity to decrease cancer risk in this high-risk population. Unfortunately, and we have in our audience really the expert in the field, Heather Hampel, we are not doing a very good job of recognizing these individuals. I think we're doing better than when she published this paper back in 2011, but the bottom line is that probably less than 10% of individuals that have the most common hereditary GI cancer syndrome, Lynch syndrome, are even aware that they have that diagnosis here in the US. Why is that? Well, our approach to identifying these individuals has evolved and changed over time. Historically, we would rely on collecting multi-generation cancer family history, and anyone who's embedded in patient care knows how challenging this can be. Not only do patients not necessarily know their multi-generation cancer family history, but in busy clinics, it's hard to collect this information. Even if it's collected, many of us don't thoroughly document it. Even if we document it, it may not be put together and acted upon. So then there was a shift towards, well, if we can't do a good job of collecting and acting on family history, maybe we can start with the individuals who are diagnosed with colon cancer and identify whether those cancers were driven by a hereditary predisposition. And that really, we were able to take advantage of and continue to take advantage of the tumor biology of individuals with Lynch syndrome, the most common hereditary syndrome, wherein we can essentially test for the kind of molecular characteristics that we expect to see, and the hallmark of Lynch syndrome being microsatellite instability, these kind of random insertions of genetic code that weren't repaired because the fundamental problem with these individuals is a genetic inability to fix these mistakes. And so you can do things like immunohistochemistry, where, for example, in a tumor, if there's abnormal mismatch repair function, for example, a mutation in the MSH2 gene, then essentially the tumor, you can stain for that MSH2 protein. And if it's absent, it may be because that patient had an inherited mistake in the MSH2 gene. Can also check for these repeated insertions in the DNA code through polymerase chain reaction, or PCR, for MSI testing, to identify whether there's a substantial proportion of these markers that suggest microsatellite instability. And so this really is a very effective way at identifying Lynch syndrome patients with a sensitivity of over 90%. And so it's really in 2008, multiple societies came together to support universal tumor-based screening. So all patients diagnosed with colon cancer, multiple professional organizations really supported doing tumor-based screening for this most common hereditary GI cancer syndrome, Lynch syndrome. So you can see all the societies, the professional organizations that support this, but the reality comes down to whether it can actually be done in clinical practice. And these cartoons are really nice to look at and simplify our approach. In fact, it's very complicated, and just like any screening program, it requires a systematic implementation of multidisciplinary stakeholders, not just the GI doctor who gets that biopsy specimen or the surgeon who performs a resection, but then the pathologist or the different departments even within pathology who do immunohistochemistry or send a test for PCR to analyze that test, to do the reflex testing depending on the initial results, and then who does that test result come back to? The gastroenterologist who scoped the patient 3 weeks ago and is now, really relying on the oncologist or the surgeon to forward the patient's care, or the surgeon who says, hey, I operated, I'm not a genetics expert. And so you can see how without a systematic navigation program, there's a diffusion of responsibility. And this is really, really challenging to implement depending on your health setting. And we know what happens when that's the case, when there's a complex cascade to navigate. And we see that in general colon cancer screening. Just in this last session of individuals who get a non-colonoscopy test and getting them to the colonoscopy, there are disparities that shake out when there's additional steps involved. And really within cancer genetics, there's no exception. This was a really nice study by Sonia Kupfer's group, wherein they actually implemented universal tumor-based screening in diverse settings in Chicago. And the great news is that because universal tumor-based screening was done, it was done across all sociodemographic and ethnic groups. However, when they looked at what happened with these patients who actually navigated to a genetic counselor and get the genomic services they needed, there were disparities. And so they just pushed the disparities down the path. So again, citing my colleague and friend Heather Hampel, this was a really kind of landmark study published out of the Ohio Colon Cancer Screening Initiative, where they performed germline genetic testing, so multi-gene panel genetic testing in all individuals across 51 Ohio hospitals diagnosed with colon cancer. And you can see that for those under the age of 50, 16% had some mutation or pathogenic variant in a cancer predisposition gene. Now you can see that it's inclusive of many different genes in addition to Lynch syndrome, but this is a substantial proportion of individuals who have a genetic predisposition to colon cancer. And based on this study, along with others, in 2017, the National Comprehensive Cancer Network then really moved to recommend direct germline genetic testing in all individuals diagnosed with colon cancer under the age of 50. So in some ways, bypassing that complicated molecular pathway to improve identification of these patients that are at high risk. This group then followed up with additional data that is really important to review. So again, 51 hospitals across Ohio, over 3,000 individuals diagnosed with colon cancer, many of whom, 1,400, who had germline genetic testing. And they identified 234 individuals with a pathogenic variant. And you can see the distribution of the different genetic changes. And I think one of the big take-homes is that there are multiple genetic predispositions to colon cancer, not just Lynch syndrome, not just the syndrome that we do tumor-based screening for. And one of the kind of couple of important take-homes from this were that tumor-based screening, that historical approach, missed almost 40% of patients with a genetic predisposition. And that included 9 patients with Lynch syndrome. So as good as tumor-based screening is, it's not perfect. And so why is it that we can't just go directly to germline genetic testing and bypass some of this complex tumor-based screening for our patients? And in fact, that's the question that we as a profession and the NCCN has been contending with. And since 2022, they actually do suggest to consider multi-gene panel germline genetic testing in all individuals diagnosed with colorectal cancer. This is a really disruptive change in the field. Offer genetic testing to all patients diagnosed with colon cancer. It's one that we're likely moving towards, and many institutions are in the process of figuring out how to do this, but you can just appreciate how big of a logistical challenge this is. This is the second most common cancer, and certainly there might be ways to implement germline genetic testing for newly diagnosed patients, but think about historically all the patients that are survivors and getting them navigated through appropriate genetic testing. It's an incredible endeavor. So there's, of course, the cost and care delivery burden potentially associated with expanding genetic testing to all patients diagnosed with colon cancer. A lot of innovative work that's being done to understand the cost effectiveness, how to implement this in a way that doesn't really overburden our precious resource of genetic counselors. It also requires expertise. If I handed a genetic testing report like this to one of my colleagues in GI, they would probably just cower away because they don't know how to interpret all the different variety of results that patients can get. So we need the expertise within our workforce to be able to know what tests to order and how to interpret them and how to arrange care for our patients that need it. And then we always have to be cognizant that as really intuitive as it might be to expand these services to all, we have to be really pay close attention to the disparities that may get pushed downstream, because of course it'd be great to expand germline genetic testing to all, but only if we're also able to offer those cancer risk reduction interventions to all that we know impact downstream outcomes and the outcome of interest, cancer incidence and mortality. So just to close on a few final thoughts, it's really a remarkable time right now in terms of sort of the emerging approach and our increasing understanding of the genetic and molecular basis of colorectal cancer. We're seeing how much it's pushing into how we can improve options for screening in our patients, taking advantage of these biomarkers that can essentially detect cancer at early stages in the stool, in the blood. But then also in our approach to precision prevention, and as we'll hear about next, precision treatment. But operationalizing these expanding options is really going to be the implementation challenge to us all. How can we do so in adapting to new delivery models, train a workforce to be able to explain all of these options all the way from screening down to multi-gene panel testing, and then of course doing so in a way that it's accessible to all of our patients. So really appreciate the NCCRT for opening this conversation to expand our attention across the cancer continuum.
Okay, wonderful. We'll keep the train going here. We have up next Dr. Andrea Cercek.
Thank you so much. I'm really happy to have been invited here to tell you a little bit about where we are with treatment of metastatic colorectal cancer. And I'm obviously incredibly excited that NCCRT is moving into treatment as well, because there is a lot that can be done in terms of being able to offer this to patients everywhere. So in terms of treatment of metastatic colorectal cancer, I always say to my patients, we're not just treating the CAT scan. We take everything into consideration. We think about the patient, their age, their comorbidities, if they've had treatment before, what their personal take is on therapy. We look at the tumor characteristics, which are important, how much organ involvement there is, how much disease, can we get the patient to surgery, where the tumor is located is important in colorectal cancer. And then, as I mentioned, patient preference. Oftentimes, unfortunately, when colon cancer is diagnosed in advanced stage, like stage 4, there is this very realistic conversation of our treatment works, but it's very often not curable. So we always say the colorectal cancer is treatable but not curable. And so there is this very important discussion with the patients in terms of focus on quality of life, focus on duration of life that is also taken into consideration. And then increasingly more importantly, and what I'm going to focus on today, are the molecular characteristics of the tumor. So Dr. Patel nicely mentioned how molecular characteristics have played a role now in screening, but they're incredibly important for us in stage 4 colorectal cancer, but also increasingly more important in actually early stage disease as well. So some of the main targets that we think about, and it's, for those of us in academics, we kind of live and breathe all of these markers. We see everyone that walks through the door with kind of a panel of molecular markers that help us guide treatment. But in the community, they are very often not done. And as you can imagine, many oncologists treat a number of tumor types, and it's really, really hard to keep up with how fast-paced all of these changes are in specific diseases. In lung cancer, everything is now targeted therapy based. In colorectal cancer also, we've made these huge strides, but there is constant new information coming in, and so it is really a challenge for those that are not in academic medicine, that don't live and breathe colorectal cancer, to keep up with all of these markers, which is why it's incredibly important to kind of continue to share this knowledge and spread the word. So some of the mutations that we look for are RAS mutations, KRAS and NRAS, which initially just told us whom not to treat, but now we're actually developing therapies targeting these mutations, which is really exciting. BRAF mutations, which I'll talk about today, mismatch repair deficiency or MSI high, and a big group of these patients do have Lynch syndrome, but not all. Many are also sporadic or randomly have MSI high tumors. And then HER2 amplifications are somewhat of a newer kid on the block for colorectal cancer treatment, but becoming increasingly more important as well, especially in stage 4 disease. So sort of like a big picture scenario of how we treat colorectal cancer. So what we really want to know, but we don't always know when we first meet the patient with stage 4 disease, is what does this molecular profile look like? Do we know if the tumor is mismatch repair deficient, is it MSI high, or is it MSS mismatch repair proficient? That's kind of the first bifurcation where we can decide whether we pursue chemotherapy backbone or immunotherapy. And then all the other mutations that I just outlined. And often they're given with a combination of chemotherapy, Often they're not given as initially when we first meet the patient, but there are now many trials that are testing some of these targeted therapies in the first-line setting. So that's why it's so important for us to know this information early on. So I'll go through all of the targeted agents. Please feel free to stop me. It's a lot of information, and I don't want to belabor the points too much, but I just do want to highlight why each of these has very exciting data and why it's so important to have these tested. So HER2, as I mentioned, is a newer kid on the block. It's been studied a lot in breast cancer and in gastric cancer, where it's been the standard of care for a long time. In colorectal cancer, there have been several trials more recently targeting HER2, and I won't talk about all of them, but they're typically a combination of a monoclonal antibody and a tyrosine kinase inhibitor, so we require 2 drugs in colorectal cancer to target HER2. And then there's also more novel therapies that are called ADCs, or antibody drug conjugates, which can also deliver therapy through the HER2 receptor directly into the cell. And that's a whole new area of exploration in metastatic colorectal cancer. So typically in advanced disease, once the patients go through first and second line of chemotherapy, there's not much response in colorectal cancer. We have a few drugs approved where patients live a little bit longer, about a month and a half, 2 months longer, but we don't see much responses, or we don't see much tumor shrinkage. So this target actually is able to, with appropriate therapy, when the patients had chemotherapy, the tumors grew through chemotherapy, first line, second line, and then they received this treatment, the tumors shrunk actually by 30%, which is incredibly exciting and really suggests that these tumors are quite dependent on HER2 for growth. So this was kind of the first clue to us that this might be a very good target in metastatic colorectal cancer. Then some more studies were done noting that it's never very clean in colorectal cancer. There's these communications in the pathways where you might target a specific target and then something else gets turned on and the cell figures out how to grow anyway. And so what we learned is that there are specific mutations that the tumor should not have in order for this therapy to work, and that's a KRAS mutation. So with that knowledge, this was a very exciting trial that was recently published, and actually the therapy gained FDA approval, where patients with HER2-amplified tumors that were RAS wild type, so did not have the mutation, who had all standard lines of chemotherapy. So their option at this point was either just best supportive care, no treatment, or some of the drugs that we had available, no responses, and prolonging survival versus just standard of care observation of about a month and a half. So this is kind of the playing field where we were with this trial when it was designed. And in this selected population, patients went on to receive the combination targeting HER2, nothing else. They had already had all the chemotherapies that we had available. And the study had these amazing responses of nearly 40%, which was just, truly unbelievable and unheard of. And, this is just to show you the downward pointing bars are all of the responses, and it's something that we rarely see in advanced colorectal cancer. So truly a very dependent, that the colorectal cancer cell is very dependent on this pathway, and that when we have a good target, incredible things happen. And of course, the most exciting part, and what we really want to see in metastatic disease, is an overall survival benefit. And here, the median overall survival was over 2 years. And as a comparator, as I mentioned, the other drugs that we had in this space, the survival was about 5 months. And so this was a huge breakthrough. And this is now being studied in the first line setting, where we hope, where the tumors have not been treated with anything, that we might be able to do even better and cure even more patients with this therapy. So incredibly important to test this as early as possible. And thankfully, many of our panels that are send-out panels that many docs have access to, even in the community, do include HER2 testing, but education is important because these reports can sometimes be confusing and these patients can be missed. So this is still studied now in the first-line setting, but it's just a very, very exciting trial, I think. And then, as I mentioned before, there's other ways to deliver drugs using this receptor. So this T-DXd is one of these antibody drug conjugates. And the nice thing about this one is that it's able to get into the cell regardless of other mutations. And here, the patients also had significant benefits. So it works very well. It's another option for this patient population, similar responses. The only difference here in this study is that there was some toxicity, probably from the potency of the drug delivered directly into the cell. And so this is something now being worked on in terms of the dosing toxicity. But this method of delivering therapy is becoming increasingly more important in all solid tumors, but even in colorectal cancer. And then BRAF is also important to know upfront. It is now also studied in the first-line setting based on this data that I will show you. BRAF is a tough one. Patients have much more resistant disease. They live shorter time than an average patient with metastatic colorectal cancer. It can involve multiple organs. Surgery is often not an option, even in somewhat localized metastatic disease, because the tumors tend to recur very rapidly. So it's a very, very difficult to treat type of colorectal cancer. But we now have therapies that target it, and I won't show too much of this data, but effectively a combination of targeted therapies, encorafenib and cetuximab, which targets this BRAF receptor, was shown to improve median overall survival in these patients. And now, based on these data and these beautiful responses that we're seeing, again, we were expecting kind of a zero response in this patient population. This is now being studied in the first-line setting. So the hope here is, again, we usually go from more advanced disease into the first line. Can we improve outcomes? Can we select patients a little bit better that might be more sensitive to BRAF targeted therapy, that have this mutation, and then hopefully improve survival and cure the subset of patients. And then the exciting therapies for many, many solid tumors, GI, pancreas included, lung as well, and then colorectal as well, are the KRAS targeting drugs. So KRAS has been historically a real problem in colorectal cancer. It's about 50% of all of our patients have a KRAS mutation. They cannot get a therapy that we have to offer because they don't benefit due to this mutation. And so now there's a huge area of focus on targeting KRAS. It comes with many, many different subtypes. So the first one that was studied was the KRAS G12C mutation. So now it's not only important to see if the patient is RAS mutated, KRAS mutated, but it's the type of mutation that matters, because there are a number of ongoing trials targeting KRAS G12C as well as KRAS G12D at the moment, but others are in development as well. And so this was exciting to see. We saw responses in combination with cetuximab. Again, a big gain for us, and now this is also actively under investigation in early stage disease. And then for something that we kind of aspire to with all of our therapies, with all of the trials that we're doing, is to be able to treat and have the responses that we see in MSI-high tumors with immunotherapy. So these are tumors, as Dr. Patel described, they can be associated with Lynch syndrome patients, many are, but effectively what they are tumors that have many, many mutations or many, many flags to where the immune system already recognizes the cancer cell as something foreign. And so when we treat with immunotherapy, basically all immunotherapy does is it takes the brakes off of the body's natural immune system. And then amazing things happen, because there's nothing more powerful than our immune system, better than any drug, any targeted therapy that we can think of. But if and only if it recognizes the cancer as something that it really wants to attack and get rid of. And with these MSI high tumors, the cells look so weird and so foreign to the immune system that the cells are already trying to attack it. And so when we give immunotherapy, the brakes come off, the T cells, our immune cells, kind of recruit an army, and we start to see these amazing responses in cancer, including colorectal cancer. So because of these responses, and I'll just show you some of them, we now have approval for immunotherapy in first line and second line and beyond in mismatch repair deficient MSI high cancers. So any Lynch syndrome patient with a cancer of 100% should be tested. Of course, all patients should be tested for this up front, because we can make that decision right away. Do we do immunotherapy, or do we need to do chemotherapy if the tumor is not mismatch repair deficient? And these are just the data to show you the strong responses of pembrolizumab, in this case a PD-1 inhibitor, versus chemotherapy in first-line patients that are mismatch repair deficient. The survival here is not significant, only because the group that received chemo first then went on to receive immunotherapy, which was appropriate, and then many were rescued with immunotherapy in that setting. And then this is a newer study looking at combination therapies, 2 checkpoint inhibitors versus a single PD-1 blockade versus chemotherapy. And you can just see the difference in the curves there, how significant the benefit is in terms of in patients that receive immunotherapy versus chemotherapy in this subset of patients. And then just in terms of what's on the horizon, about many of our patients, 95% of them do not have mismatch repair deficient or MSI tumors, but have MSS tumors. And these really, their sort of bottom line move is that they completely hide from the immune system. They're what we call immune cold. They set up little blockades for our immune cells, and they're just kind of hiding under this cloak, whereas the MSI high tumors are sort of very, here I am, please attack me type of tumors. And so that's really the fundamental difference. And so when we first tried immunotherapy in these tumors, nothing happened, absolutely nothing, because the immune system didn't see them at all. And now there's a number of ways that we're thinking about basically tricking the immune system into recognizing the cancer cells, from better drugs that might recruit the immune system better, to vaccines or radiation, where the thinking is that the radiation releases these neoantigens or little flags for the immune system then to recognize those parts of the cancer cell as foreign. And then other ways to almost like, they're called bispecific antibodies, where we almost like flag the cancer cell with an antibody that then kind of sticks out and the immune system recognizes that as something that it wants to fight. So there are a number of trials ongoing in this area, and I think, we are definitely making progress, which is incredibly exciting. And I think certainly over the next, few years, we're going to see huge strides in this patient population. And just to show you, this is an early study in this population where, again, initial data, absolute zero response. But these are newer drugs, botensilimab and botensilimab, better ways of recruiting the immune system from the botensilimab, which is an Fc-enhanced anti-CTLA-4 drug, but response rates in the 20%. And so that's a major step forward. You see these beautiful downward sloping lines in terms of responses. And then most important, as I said earlier, is overall survival. And that's really what we want to see. We don't want to see just short responses and then the cell figures out how to live and we have to move on to something else. We want to see durable responses. And the beauty of immunotherapy really is that it engages our immune system. Our immune system teaches itself, just like when we get a vaccine, to recognize that as something foreign. And I think we're seeing hints of this translated here because these responses do seem to be durable, which is incredibly exciting. So in conclusion, colorectal cancer treatment now in the metastatic setting is all about targeted therapy. We certainly, of course, use chemotherapy, but we really need to know main mutational status as early as possible, hopefully when we first meet the patient, so we can make that treatment decision, whether it's standard of care treatment or perhaps a clinical trial. And there's many different ways to do the testing. Many send-out tests are available. And of course, huge importance of clinical trials for our patients, because that's really what moves treatment forward. Thank you very much.